I'm going to say good. Um, yeah, as you all heard, this webinar will be recorded and it will be uploaded to the Lebanese Ministry of Public Health's YouTube channel. So hopefully you can all access it later on. I'll say good evening to everyone in Lebanon and a good day to everyone who's joining us from all over the world. And as you can see, Dr. Laurent and I are here from Australia waiting for this 4 a.m. coffee to kick in. And all credit to daylight saving that's happened 2 days ago. As you all join us, please remember to fill the attendance sheet. I saw that there were some technical issues with filling it in, but I think Maurice has already fixed that. In the chat box, you'll see the link. So just fill in your attendance sheet for your certificate of attendance at the end. And while I give a chance for everyone to join into the meeting, I'll ask if you can please also let us get to know you. So in the chat box, if you don't mind putting a name, a background, and where you're tuning in from, just few words, that would be great. Together, what kind of diaspora we're dealing with. It's roughly 49 participants so far, so that's fantastic. I'll give you a minute just to put in your name, background, where you're tuning in from, and then we'll start. And before I introduce myself, actually, I really want to acknowledge the true powerhouse behind this webinar, and that's Miss Maurice Aboud. Maurice has been very efficiently and seamlessly putting this webinar together, and she's currently behind the scenes, as we speak, setting the wheels in motion, and she'll be mopping up any mess we create. So we're very grateful to you, Maurice, and we extend our thanks from the panelists and I and all the participants for all your hard work.
Thank you
now
so
back
much.
to me. Sorry.
Thank you so much. It's my pleasure. Happy to support.
Thank you, Maurice. So my name is Christiane Melki, and I'll be your session moderator, which is a lot more exciting than I expected. Besides needing to wake up at 4 a.m., I actually get to meet and introduce truly inspiring people. So I'm very excited to be here today. And I'm an emergency medicine trainee, currently working at St. George Hospital in Sydney, Australia. I'm the former president and the current vice president of the Australian Lebanese Medical Association, ALMA, the New South Wales branch. And it's true I'm speaking in English. However, I'm very proud to say that I was born and bred in a small village in Lebanon, North Lebanon, called Ram al-Kura. And before moving to Australia and completing my master's in public health and MD here in Sydney, I acquired my pre-medical degree at the American University of Beirut, which brings me to one of the most exciting and most, biggest highlights of this webinar. And I'm honored and very, very excited to welcome His Excellence Dr. Rakan Nasruddin, our current very established Lebanese Minister of Health, who is also a dear friend of mine and an AUB alumni and a true role model. This is Dr. Nasruddin's first attendance to one of ALMA's webinars, and these webinars are usually woven in collaboration with the Lebanese Ministry of Public Health and the UN IOM. So Dr. Nasruddin, please share with us your opening remarks.
Hello. Well, thank you, Christian, for this lovely introduction. First of all, I would like to insist on the shared history that we together share at AUB at the pre-med level. I really miss those days. We shared 3 nice years together at biology at pre-med school at AUB before I continued my residency and my training at AUB and then at University of Toronto. And now I'm serving my country and my citizens as a Minister of Public Health. Well, I would like to extend my greetings to all all guys at ALMA, at the Ministry of Public Health, at IOM, for organizing these sessions. And I would like to insist on the importance of these sessions and not only in delivering medical knowledge, but also in cooperating between the Lebanese sectors and Lebanese people to help in the service. Today, I know that the session will be about the cervical cancer and HPV vaccination, which is really an interesting topic that we are facing at the same time in Lebanon and also in the world. WHO has proposed several points and if you want, like expectations that we are at the Ministry of Public Health working on, starting from the importance of vaccination, early detection, and a treatment plan. I would like to insist also on the importance and the important role at the preventive level, where we as in the Ministry of Public Health are working with our primary healthcare centers to provide the HPV vaccines, and that is the only preventive measure that we can really make in the context of cervical cancer. Knowing the prevalence and incidence of cervical cancer, we've noticed an increase, a rise in the rates of cervical cancers among the Lebanese population, also worldwide. And as you know, this is a preventable cancer that we can really treat if we deal with it properly through proper campaigns, through proper vaccination, and also through an education. You know, in Lebanon, we lack the educational part at our citizens regarding the risks and the benefits at this in this part. So again, I would like to thank you all for attending. Thank you all for organizing this. Thank you all for even waking up at 4 o'clock in Sydney. Is it 4 a.m.?
Yes,
Thank you.
it is.
Oh, okay. But you look so fresh, huh?
Makeup does wonders.
And also, in addition to that, I'm looking forward for more cooperation with you guys. The power of Lebanon is basically based on his people that are living in Lebanon and abroad. I was in Toronto for a short period of time, and I know the feelings when you are committed to your country and you feel the belonging, where you always try to find any way to help, and there is nothing helpful than being in cooperation with your people at the Ministry of Public Health. This ministry is for all. It serves all, and the ministry is only a title that is the big server.
Thank you, Dr. Nasruddin. It was such a pleasure seeing you again and hearing again how inspiring you are. So thank you for joining us. We know you have a very busy schedule, and I hope you can tune in as long as you can.
Actually, I would love to, but unfortunately, I have a meeting that is ongoing now. So,
of course,
so
of course.
I apologize for not being able to continue the meeting. We'll get a briefing from the team, and please let me know if you need anything, any support from the governmental level. We are here to help and to make things as easy as possible from a governmental, a public. From a governmental and public point of view.
Fantastic. Thank you, Dr. Nasruddin. Enjoy the rest of your the meetings. Bye.
Have a good day.
So today's webinar's aim, as you can all see, it's mainly to talk about the latest and greatest on HPV and cervical cancer, and to shed some light on the contrast between Australia and Lebanon. So, for instance, in Lebanon, as we just heard, cervical cancer, which is often linked to HPV, is a significant health concern. And recent studies have shown that among Lebanese women, awareness as well as cervical screening, and then the HPV vaccination uptake is quite low. In contrast, Australia is on track to become the first country in the world to eliminate cervical cancer as a public health issue by 2023. So this will take me to our agenda. As you can see, Ms. Maris Haboud has very well crafted this agenda. So from 9:10, which is exactly now, to 10:15, we'll be going on a journey with Professor Atallah and Dr. Milham on HPV in Lebanon and Australia. And then we'll go through a complex case-based discussion where Professor Atallah will guide us through a case he's had, and we'll hear the panelists discussing this. I know that there might be some burning questions throughout these sessions, but if you don't mind, please keeping the Q&A till the end. We've felt that this might be the best way to go ahead with that. So you can either put your questions in the Q&A box in the chat, or you can wait till the end and we'll have a live back and forth Q&A session. Now, some housekeeping rules. Microphones will be muted for all attendees, and questions should be shared in the Q&A box, like I mentioned, or left till the end. And then once we reach that Q&A box, then you'll all be allowed to unmute yourself and participate. Of course, we're all kindly invited to remain respectful. And as mentioned, participants who attend till the end will get the certificate of attendance. Now, Maris is very lovely, but she's also very strict. So Professor Atallah and Dr. Milham, I was told to be a very strict timekeeper here. So I'll be giving you a 5-minute mark at the end, just to remind you that we're approaching the 20 minutes mark, if that's okay with you. And that way we'll keep the time. Before we start, I'll ask Maris to please take a moment to share the poll survey, and for you all to just take a second, have a quick read of this and answer. And then in a minute, we'll share the results. Maris, if you think we have enough answers, do you mind please sharing the results? Very good. Thank you. All right. Moving on to the session speakers, and again, the highlight where I get to introduce such fantastic people. Professor Atallah, I'll need to take a breath to introduce you. You're very well established. So Professor Atallah is a gynecologic oncologist and breast cancer surgeon. He earned his medical degree from St. Joseph University in Beirut and a master's in clinical research from the University of Liverpool. He currently serves as the chairman of the obstetrics and gynecology department and head of the gynecologic oncology and breast cancer unit at Hôtel Dieu de France University Hospital in Lebanon. He's actively involved in global medical societies, such as International Gynecologic Cancer Society. He's the president of the Lebanese Society of Obstetrics and Gynecology and the VP of the Lebanese Gynecologic Oncologic Group. He's a prolific researcher with numerous publications. His work spans diverse topics from ovarian tumors to hyperthermia and cancer treatment. He's honored with accolades like the IGCS Excellence in Teaching Award. Professor Atalla's dedication to advancing medical knowledge and patient care remains steadfast, defining his profound impact on the field. Professor Atalla, it's again a pleasure to have you with us. I will stop sharing my screen and ask you to share yours if that's okay.
Thank you very much. Thank you. I want to, excuse me, I'm trying to find my, okay. Okay. Thank you. Excuse me, I cannot, not able to find my,
If you need us to share, let us know, Maris, if you're happy to, unless you have the updated ones.
I have updated one, excuse me. Know what's happening, okay. Need to, okay. Okay. 1 minute, excuse me. There's a problem. Okay. It has to share.
Dr. David, if you'd like to send it to me by email, and I'll be happy to share. I think this would be quicker.
That's what I'm going to do.
Yeah.
Okay. Okay. But we tried that and it worked. I don't know why it's not working now. Okay, anyways. Okay. What's your, I'm going to, okay.
If you'd like, we can start with Dr. Laurence, and that way I can handle it with you, Dr. David, privately on WhatsApp. We'll figure it out. So, Christian, if you'd like to introduce Dr. Laurence, and if you're ready, Dr. Laurence, we're here. We're ready to listen to you.
Yep,
Okay.
I'll just unmute my video. Yep. Can you share?
I have the pleasure to introduce Dr. Laurence. Before I share your screen, or maybe, I'll share your screen, but I'll introduce you first. So Dr. Laurence Melhem is an obstetrician and gynecologist with a particular focus on women's health, fertility, and laparoscopic surgery. She earned both her medical degree and a master's in reproductive medicine from the University of New South Wales in Australia, and she's a fellow of the Royal Australian College of Obstetrics and Gynecology. With over 20 years of experience, Dr. Melhem currently serves as a visiting medical officer at several leading hospitals and centres, including Westmead Private and Public Hospital and IVF Australia. She's also a very active member of the Australian Lebanese Medical Association and the Fertility Society Australia. Known for her comprehensive, caring, and individualized approach to patient care, Dr. Melhem has built a strong reputation in fertility treatment and advanced laparoscopic surgery, contributing to her high success rates in fertility procedures. And may I add to this biography as a peer review from personal experience that Laurence is a wonderful human being with a heart of gold. So Laurence, I'll start sharing your slides in a second. Let me have a look. And again, thank you for waking up at this time and joining us.
Thank you. Thank you for that big introduction, and thank you to everyone who's joined in. And honestly, what a pleasure to sort of be part of this wonderful program and just spreading good news and awareness to everyone so that we can improve our health and our mother country's health as well. Okay, so I'll start by saying that this is a very important topic, HPV and cervical cancer, and Australia has really been a leading country in pursuing these changes to try and make a big difference in the world. So basically, I'm just going to talk a little bit about HPV and cervical cancer and just some of the new treatment strategies and advances in prevention and management. Next slide. Yep. Oh, sorry, we've gone ahead one. Okay, so the majority of cervical cancers, as you know, are caused by the papillomavirus, and there've been about 12 HPV types that are known as carcinogenic. The main ones we identify are HPV 16 and 18, which are known as the high-risk ones, and there's a several group of the low-risk ones put into the category of other. HPV 16 and 18, as we know, are the most carcinogenic, being responsible for at least 70% of cancers. So the important steps to note is, firstly, HPV infection acquisition. Secondly, viral persistence versus clearance. Thirdly, progression to cervical precancer. And lastly, invasion. Next slide. And this is just a little diagram just to basically show you. And the important strategies that are being introduced today is to try and get involved at this point here where it's secondary prevention, that once a woman is infected, that we monitor, we screen, we do surveillance so that we can definitely prevent it developing into a cervical cancer. Next slide. So cervical cancer is known as the 14th most common cancer in women and people with the cervix, and the 17th most common cancer death amongst this population. In 2019, there were about 945 new cases of cervical cancer. In 2024, there's going to be an estimated over 1,000 cases that will be diagnosed by the age of 85. In Australia, cervical cancer incidence is biggest amongst the Aboriginal and Torres Strait Islander females, and they stand at about 13 per 100,000 approximately, which is twice the national rate. This is because what we found in Australia is that those that live in low socioeconomic areas and very remote areas such as Aboriginal and Torres Strait Islanders are very underscreened or not screened at all, and hence the incidence of cervical cancer is a lot higher in this group. Next slide. So this is just a graph basically showing all the way back from 1982 up until 2018. And as you can see, the incidence of cervical cancer in Australia has definitely dropped over down to at least 6% at this point. Next slide. And this is just another one basically just showing you how the rates have definitely decreased. The actual estimate of cervical cancer has dropped, and this is something that we try to continue to pursue. Next slide. So once again, just a review of the statistics. Estimated number of cases by 2024 is over 1,000, which is estimated at 1.4% of new cancers. 243 deaths estimated from cervical cancer, and at least a 75.5% chance of survival of at least 5 years once diagnosis is established. Next slide. So the important thing with cervical cancer, it's known as one of the most preventable cancers, primarily through screening and vaccination. The thing is with cervical cancer, compared to other cancers, it has a long precancerous stage, and it gives the opportunity for detection and management. And that's why it's very important to have screening programs and things like that to be able to intervene at an appropriate time to improve the mortality and morbidity associated with this. Next slide. So the three things that I want to talk about today are the advances in HPV and cervical cancer management. 1, screening improvements. 2, vaccination. And 3, treatment advances. And I'll really focus on the first one and the second one. Next slide. So cervical cancer, as I stated before, is a very preventable cancer. Early detection and treatment can significantly improve cancer survival. In Australia, since the introduction of the National Cancer Cervical Program, the incidence and mortality rates have halved significantly. And over time, they've renewed the program. So we introduced the screening back in 1991. We've done a revision in 2017. And most recently, there's some updated guidelines that will be introduced in the next week or so, and I'll touch on those in the next few slides. Next slide. So screening improvements. So what was being introduced is HPV testing, which is more traditional than the pap smear. Back in the day, they did the pap smear where they were just checking the cell, looking at cells to see if there was abnormal cells or not. Now we take it one step further. We do HPV testing where we detect the high-risk strains versus the low-risk strains, and then we manage accordingly. Secondly, the co-test, which combines the HPV testing and the pap smears, and this has now become the gold standard in Australia for guidelines, and this has a high sensitivity for detecting precancerous cells. The third introduction of what Australia's done is self-collection and self-sampling, and this has made a significant contribution to reducing the cervical cancer rates. Next slide. So the updated changes in the cervical program also recognise the introduction in 2007 of a vaccine against specific strains of the HPV virus. The new screening program is also designed to work with HPV vaccination program to overall reduce the incidence of cervical cancer. And the cervical screening test detects infection with HPV, the virus that does cause the abnormal changes in the cervix, which, if left untreated, can lead to cancer. Next slide. So let's talk a little bit about the HPV testing and the co-testing. If oncogenic HPV is detected, what they then do is either high-risk type, which is the HPV type 16 and 18, or the low-risk type, which is otherwise known as non-16, non-18. Depending on that result, if the HPV test comes back negative, then the management accordingly is to rescreen in 5 years. This is the screening that Australia has introduced. If it comes back that any of these is positive, it automatically initiates a reflex liquid-based cytology, which is applied to all the HPV positive samples, and then the woman is triaged according to the risk levels, either low risk, intermediate risk, or high risk, and the management will happen accordingly. Next slide. So just to talk about the national screening program, it's aimed at women between the age of 25 to 74. The aim is to reduce illness and death from cervical cancer, and the test is performed every 5 years whether the woman is vaccinated or not. Next slide. So as I showed you before, the incidence of cervical cancer has significantly dropped, and so we in New South Wales are sitting at a rate of about 6.3%. If you look at the left-hand side of the slide, Aboriginal and Torres Strait have double the rates, but once again, this is a very largely underscreened or not screened population, and this is to do with the low socioeconomic standard and the remote living. Next slide. Mortality, obviously a lot higher in this group compared to the rest of the population as well. Next slide. So the current national cervical screening strategy, this was based on improved knowledge and the natural history of HPV infection and cervical cancer. So as I said, it was introduced back in 1990, but it underwent a significant change in December 2017. The program ended up being transitioned from a 2-year cytology screening, which before included women from the age of 18 to 69, to now a 5-year primary HPV screening program between the ages of 25 to 74. Secondly, because they introduced the National HPV Vaccination Program in 2007, this has significantly resulted in a rapid reduction in precancerous lesions. And this is why they increased the age from 18 up to 25. Because they were introducing the vaccination program in schools, they were giving women the opportunity for the virus to be rid of themselves, and then they introduced the screening from 25 onwards in a chance that the body's eradicated the virus, and if not, then we start picking up and managing accordingly. Lastly, HPV using self-collected sample was also introduced as part of the renewal with the aim of increasing participation by women who had never been screened or under-screened people. Next slide. So the whole aim is towards eliminating cervical cancer, and Australia has been one of the leading countries in this. And the aim is to recognise the preventable nature of cervical cancer and calling out the substantial inequities between countries worldwide in its prevention management. The World Health Organization has called for all nations to strive towards eliminating this cancer as a public health problem. Next slide. So as we stated about the World Health Organization, they introduced the 90-70-90 targets. And basically, Australia's played a big role in this. And the 3 key strategies, and the aim is for the target to be reached by 2030. One is to increase the HPV vaccination rate to 90%. 2 is to encourage at least twice lifetime cervical screening to 70%. 3, the treatment of pre-invasive lesions and invasive cancer to 90%. And this is the roadmap that they aim for to 2030. Next slide. Yep. This national strategy for the elimination of cervical cancer in Australia was announced in November 2023. And it's a pathway to achieve the elimination of cervical cancer as a public health problem. And the aim is to try and reach this by at least 2035. Next slide. This is basically just a slide just to go through the 3 different things: the prevention of cervical cancer in ways like screening, vaccination, and obviously treatment with the new and introduced technologies that we can try and introduce. Next slide. I just wanted to highlight here to show you the difference between Australia and the WHO targets. So as you can see, Australia, there have been 6.5 new cases per 100,000 compared with the World Health Organization target of less than 4 cancers per 100,000. From a vaccination point of view, at least 80% of females aged 15 years old in 2020 were fully HPV vaccinated, compared with the target of 90% of girls to be fully vaccinated by the age of 15. Screening, 67% of women aged between 45 to 49 have participated in the cervical screening program between 2018 to 2021, compared with the WHO target of 70% of women to be screened between 35 and again by 45 years of age using the HPV screening tool. And treatment, 85.8% of precancers were treated within 6 months in Australia, compared with the WHO target of 90%. So as you can see, Australia is definitely on track and also probably one of the leading countries trying to meet these targets. And I'm sure by the time we hit 2030 and 2035, we're going to do our significant best to decrease and try and eliminate this problem. Next slide. So cervical cancer screening, as I said, it was introduced in Australia in 1991. And Australia has done a lot to invest in many ways to organise a very national program, a screening program to try and get women involved. And this is being done by Pap test registries. Now Australia has become a nationwide screening program. Whenever a woman has a Pap smear, it's registered on a Pap smear register. And so things are in place so that, for instance, if a woman hasn't come back in 5 years for her screening, then a letter gets sent out. There's government regulated labs, quality assurance. There's a lot of education out there to try and encourage women to have Pap smears and to try and recruit women into these programs so that we can try and stay on track. Next slide. So as I said, the renewed program was introduced in December the 1st, 2017. It included primary HPV testing, where we did the high-risk testing of HPV 16 and 18, and the low-risk testing of HPV non-16 and non-18. And this cytology triage was to be introduced at the age of 25, with a view that if it was negative, it would be done every 5 years. The exit HPV test would be at the age between 70 to 74. In Australia, we have a Medicare program and it's all covered under Medicare. And the focus has now been on Aboriginal women and, as I stated, the low socioeconomic status group, which is the under-screened or non-screened group. Next slide. So basically, a negative HPV test would put a woman at low risk, and that means she would be rescreened again in 5 years. Obviously, if there are other clinical risk factors or other problems, she can present any time, but based on the results, if it was a negative HPV result, she'd be considered a low risk. Secondly, if it was positive for HPV 16 and 18, this is the high risk type, so she would be in the higher risk category. Or if it was positive HPV with the non-16 and the non-18, it would be intermediate risk. Or if it came back as high risk or high grade cytology, she'd be considered high risk. Lastly, if it was unsatisfactory, obviously, we then attempt to just repeat this within a 6-week time frame. Next slide.
I'll just say it's a 5-minute mark, Dr. Melhem, please.
Yeah, sure. Yeah. So I'll just go on. If you just go to the next slide, I'll just skip through if there's 5-minute mark because there's a few other things. Just skip through. Yep, keep skipping. So this is the national screening update. I'll go to the next slide after this. So in 2025, in the next week or so, they've updated the screening program. And I mean, this slide basically just goes through some of the changes that they've introduced. And all it is basically refining the screening. So I'll just move on so that we can just get through the next few slides. Next slide. This was something very important that was introduced, the universal self-collection in July 2022. For those women who didn't want to present for a pap smear, basically they could do a swab themselves. And this was an important part of the whole screening. Keep going, next slide. There are people that are going to be eligible and there are going to be people that are not eligible. Next slide. And obviously it has to be monitored by a healthcare professional. Next slide. This is the tube, so the woman can basically swab herself, put it in the tube and submit it, and as long as a healthcare professional follows it on. Next slide. This basically goes through who is eligible for self-collect, and then the next slide will basically go through who is not eligible for self-collect. Sorry, I am rushing through just so I can get through to the end. Obviously, anyone who requires a co-test, because the limitations of this test, it only tests for HPV. If someone needs LBC or the cytology, this is not suitable. If they've had adenocarcinoma in situ or high-grade changes, or if they've got clinical risk factors, we do not recommend a self-collect. This is mainly aimed at the underscreened or people who really don't want to screen as a screening tool. Next slide. Just keep going, next slide. And once again, the results is whether you go into a high risk, low risk category, it detects HPV 16 or non-16, non-18. Next slide. Keep going, next slide. Basically, the results are going to be the same in terms of the HPV. Just keep going. I just want to get on to the next slide. Keep going. We'll just skip past. So prevention, this is the next important, is the National HPV Vaccination Program. It's aimed at young schoolgirls. We introduced it in the school from age 12 to 13. Young women catch up at age 14 to 18. And it's a non-valent vaccine. It's against 9 viruses. As you know, there's over 100 types of the HPV vaccine. The vaccine only protects against 9 viruses. Move on to the next slide. The take-home message with the HPV, it was also extended to boys from January 2013 as well, to be able to give to the young women and to the young men. This does not prevent women having pap smear screening or tests, but it is an important part of trying to reduce cervical cancer. Next slide. Just to go on a little bit about treatment, minimally invasive surgery. If it's diagnosed early, we can do laparoscopic or robotic surgery. Next slide. Some of the standard treatments is LETS procedure, where we go in and burn the top layer of the cervix, or comb biopsy, which is now starting to fall out of favour a little bit because the aim is to try and preserve fertility and prevent progression, and there are a lot of side effects associated with the comb biopsy. Next slide. Some of the treatment advances, chemotherapy, radiotherapy, immunotherapy. Obviously, this is another big topic in itself, but obviously new things are coming through. But the main thing is that there are treatment advances for cervical cancer. Next slide. Couple of the biomarkers that we do use. We don't use P16 INK4A as much in Australia. It does detect proliferation of abnormal cells. Sorry, we use P16, but not the Ki67, which is the proliferation. The P16 tells of the aggressiveness of the virus. Next slide. In the future, the main thing is falling rates of HPV positivity, screening, vaccination, increased awareness and education. Next slide. The unusual patient that we need to be aware of is the underscreened and poorly managed. And then my last slide, just to go through some of the summary. So new cervical screening program is working well. It is due for renewal. The new guidelines will come out next week, and I did touch on a few of the changes. Prevention is key, boosting public awareness, encouraging vaccination, especially in the school at the young age of 12 to 13, screening as much as possible. We touched on the WHO roadmap to try and eliminate cervical cancer by 2035. And the biggest issues that Australia is having is obviously participation, but we've tried to combat that with introducing universal self-collection. But there is still a lot of underscreened patient, as I mentioned that before, it's especially in our Aboriginal and low socioeconomic communities. Thank you.
Thank you very much, Dr. Malhem. That was very inspiring to share, why the reasons why Australia is quite advanced in its on its elimination pathway, because we've got really good vaccination program and really good screening program, and then a really good follow-up within the 6 months for the treatment. So that was very inspiring. I really appreciate it. Any burning questions, please, everyone, put them in the Q&A box. I'll stop sharing the screen now, and then we can move on to Professor Atalla's, if he's ready. I'll just have a quick chat to them to see if they've.
Okay, thank you. So you can share my presentation, please. I have some problem in sharing the presentation now. Okay. Okay, thank you. Please, can you put it in full? I cannot. 1 minute. Okay. 1 minute. I'm not seeing the whole. 1 minute. Okay. Okay, thank you. Thank you for this introduction, and I'd like to extend my introduction, my thank to the Minister of Public Health and to all those who collaborated to the success of this webinar, starting from Maryse, and I'm happy to meet you, Christian and Laurence. And so here we have here in Lebanon, we have the other side of the picture. You have seen the screening, a successful screening in a country, which is Australia. They are the champions in prevention of cervical cancer. Now we'll see what's happening in Lebanon. Please, the next slide. Next slide. Okay, so this is a slide that I borrowed from Aaron Dean from Manitoba. You see the incidence of Canada is 8.3 per 100,000, and they are aiming of having a cervical cancer incidence of 4 per 100,000, like the aim of Australia. When they are having a cervical cancer rate of less than 4 per 100,000, they are considering that they have won the battle over cancer. Next, please. But still, in our part of the region, as you can see here, we have in Western Asia, the incidence of cervical cancer is 4.1 per 100,000. Next, please. And you can see that the incidence of the prevalence of HPV in normal pap smears in the world, the median is 11.7%. In Western Asia, it's 1.7%. And next, please. And in Lebanon, no, the one before, please. And in Lebanon, as you can see here, in Lebanon, the incidence, the prevalence of HPV in normal pap smear is like North America. It's not like Western Asia. It's 4.7% of HPV positive with normal pap smear. Next, please. Moreover, you can see that 12% of patients having screening have HPV plus or minus abnormal pap smear. And you can see that the subtypes that we are finding here, and you understand why the incidence is low, the subtypes we are finding in Lebanon, the most frequent is HPV 56, 59, 66, and the other subgroup 68, which are considered as low risk, low high risk. And you can see that 17% is HPV 16, another 18% it's HPV 31, something that is very high risk HPV that's not considered high risk in Australia. Next, please. And you can see that, yes. And you can see here, this is a slide from Jack Kuzik. And this slide from Jack Kuzik stating that HPV 16, 33, and 31 are always, and the 18 also, are always in the top 3 or 4 when we are doing genotyping in cervical cancer. So we must consider the 33 and 31 as a high-risk HPV. And you can see in Lebanon, we have the 66. That's one of the most frequent. And you can see the 66 is considered in the group C and considered can be downgraded as a low risk. Next. But still, we are seeing cancers with the 66. Moreover, next, please. You can see that, next. You can see that 4.5%, excuse me, previous one, previous, okay. So you can see in Lebanon, we have HPV 66, which is the most frequent, and you can see 32% have normal pap smears, but the others have abnormality in their pap smears. Next, please. Next, okay. So 4.5% of HPV positive have normal pap smear. Next, please. And you can see this, the distribution throughout the world in 2008. Next, please. And you can see that's our region. Next. And you can see that in Western Asia, we have some particular cases like eventually UAE, that they have a little bit higher incidence rate. But it's important here to see that the rate of HPV infection in cancer samples, so we found a lower rate, 77% of infection compared to worldwide estimate. It's maybe due to genetic polymorphism. Next, please. So we are, as you understood, in a low prevalence setting. Next, please. These are the statistics of 2008. Next, please. You can see in Lebanon, it's 3.8 per 100,000. That was in 2008. Next, please. And you can see that the incidence in 2018, 10 years later, that's from the publication of Mark Arbin, it was 5.7 per 100,000. Next, please. And you can see that there is an increase, a slope increase in the incidence of HPV with time. And this was the statistics of 2018 according to the Minister of Public Health. Next, please. But look at what we found. That was in 2018. We had a 192 cases in Lebanon. But this 2018 figure disappeared from the data of Ministry of Public Health for a certain time. And now it reappeared as in 2018, we have 88 only, 2019, 131, 2020, 89, and it stops here. And if you go to the IARC, you have 144 in 2022. You can see that these figures are inconsistent. And the 192 figure is the most reliable because it has been published in the Lancet journal. Next, please. So these are the figures that you are seeing in the Ministry of Public Health. Next, please. Next. So, moreover, in Western Asia, we have a high incidence of cervical cancer after 75. You are stopping your screening at 75. Here, we must continue after 75 because we have a high incidence of cervical cancer. And in Lebanon, you can see the proportion of patients having cervical cancer after 75 are the highest in the region. Next, please. And you can see that the death toll is the higher in the region. And you can see the crude mortality rate is higher. And you can see that the age standardized mortality rate is higher. Next, please. And guess what? Next. These figures were deleted from the Ministry of Public Health site. The population in Lebanon was estimated to 6.8 million. Instead, it has rose in a year of 2 million. It's impossible. Instead of 4.5, the denominator was increased, reducing the incidence of disease. Next. According to the IARC, in 2021, our population increased exponentially, including the refugees. Next, please. Cervical cancer is not listed for the refugees. They do not report their cervical cancer. Next. This makes our crude incidence rate of 3.66. Lawrence, if you have a crude incidence of 3.66 in Australia, you say we won the battle over cancer. Here you are diluting the population. You are increasing the denominator. You are diluting the effects. So cervical cancer is no more of concern in Lebanon. And this is dangerous. Next, please. So that's our population, 6,825,000. Next, please. So I'm not dreaming. Next, please. Look at the incidence of, that's the publication. Huh? The incidence is more than around 6%, 6 per 100,000. And you can see that this is the distribution. Next. And this is the distribution in the Middle East and the Mamago countries. And you can see the highest rate is for UAE because they have a lot of migrants coming from Europe. You are seeing the incidence of Europeans or Australians or Chinese or Indians. Next. Because there the foreigner report their cervical cancer. And this is the rate in Egypt that was published 20 years ago, 25 years ago. You go to the site of IARC, you see Egypt has an incidence rate of 1.37 per 100,000, which is very low. It's untrue. Next, please. So you need to look into figures. So according to the ISCCP guidelines, there is this change in paradigm of screening. The screening has to protect ahead of time the risk of developing cancer. Developing cancer is a continuum, starting from infection happening long time ago. So taking patient holistically is essential in order to predict a risk. Next, please. And we are screening in a low incidence setting. Next. So we have less CIN2 plus in the pap smear. So you need to have an automated mean to do screening. Next. So we need to implement. Next, please. That's the problem of not controlling my slides. Next, please. So this is the problem here. You need to use the primary HPV testing in order to overcome this low incidence setting. Next, please. The low prevalence of CIN2 plus that you are finding on pap smear. So, but the problem, you will need more colposcopies. You will need more expert in colposcopies in order to perform these colposcopies. So you are sending more patients to colposcopy. Next, please. Next. So in Lebanon, we are in low prevalence setting, but an alert has to be triggered because of an alarming increase of incidence. We are seeing the patients, we are seeing the increase of HPV. You have a lot of HPV that will translate into cancer in few years. So how can we reduce more, knowing that our actual rate is comparable to the projected rate in Australia after vaccination? Here, HPV primary screening is a solution, along with vaccination. Next, please. We have limited resource, so we need to choose a pragmatic way. And I will end up my presentation with this pragmatic way. This is an important publication showing the projection in 100 years. No one from us will be here in 100 years. This is a projection of those who were eventually vaccinated in 2015. What will happen to the population in 2100? You see here that this is the red line. There's a decrease in the incidence of cervical cancer with vaccination by vaccinating young persons. But you can see at a certain point, you have a blue line and the red line that's continuing down. The blue line are those who are not screened, and the red line, those who have been screened twice in their lifetime. Next. So you can see that the incidence will be so much low that it will be anecdotal. Moreover, you can see here, considering the 2 dose that was the quadrivalent vaccine, comparing unvaccinated to single dose, to 2 dose default cohort, 2 dose cohort, and 3 dose, you can see that for the HPV 16 and 18, the quadrivalent 2 dose was like the 3 dose. And you can see here that for HPV 31 and 33, you can do with a single dose, or you can do with a double dose with 2 doses, and it will be fine with you. So you can do with the quadrivalent only that has a little cross protection. You can do with 2 doses. Next, please. At what age should we vaccinate? You can see here that. Next. You can see here that for girls between 15 and 19 years old, the effect of vaccination starting the 2nd year. And if you vaccinate the catch-up between 20 and 24, the effects start 4 years later. And if you vaccinate after 25, you don't have effect in vaccination, as you can see here. Next, please. So those are the population that have the best effect if you are starting vaccinating at 15 years old. Next, please. Instead, this is another publication showing that vaccinating before 17, practically the risk of developing cervical cancer is 0. Next, please. Same conclusions. You can see vaccinating before 16 years old, you have 0 incidence. Next, please. Same story. Next. This is another publication also. Next. You can see the green line, 0 incidence of cervical cancer. Those who, and this is interesting slide. This is an interesting slide because in Scotland, it's like Australia, they have a 90% coverage of vaccination. And you can see that those who had complete regimen between 12 and 13 and incomplete regimen between 12 and 13, the cases of disease, 0. Okay? So you can give 1 dose for these. Next. So that's why Australia and the UK moved for a single dose from 9 to 14, 1 to 2 dose schedule from 15 to 20, and 2 dose at must, as you can see, after 21 for the catch-up. Next, please. And I go back to the HPV 16, 31, 33. You can see here the cumulative specificity of cancer for the 33, 31, 16, and 18 is the highest. So do not forget, you need to consider the 31 and 33 as if it was 16 and 18. In Lebanon, we have low resources. We have no more money. We were rich. We don't have any more money. We are not rich anymore. You need to do a pragmatic way. 1 dose for every young girl, or you can do it gender neutral. Ideally, you need to vaccinate 60% of girls and boys, 1 dose before 14. And screen this population twice at 35 and 45. Next, please. And this is, as you can see, the purple line are girls only vaccinated with twice lifetime screening. And you can see the incidence of cervical cancer that went down to 0. And it's the best regimen. So we need to find the best cost-effective regimen and apply it to Lebanon. Next, please.
We're just at the 2-minute mark, please, Professor Atal.
Excuse me?
Sorry, you're almost done. I was just telling you we've
No,
got
no,
the
I'm
2-minute
done.
mark.
I'm organized for 20 minutes. It would have been faster if I would have controlled my. So next, I didn't finish. I had a slide, please. I didn't finish it. So slide before, please. So you can see this is for the low middle income countries. Next, please. This is for the low middle income countries, all cumulated. Next, please. And this is for the Western Asia, North Africa and Middle East. You can see we have a low incidence, but still the purple line works. It's the best regimen we can use. Next, please. Thank you.
Thank you very much, Professor Atallah. That was also extremely inspiring. And as we know, prevention is better than treatment. And as you mentioned, if we start prevention in such a young age, that would be ideal. And hopefully we can pitch this to the Ministry of Public Health and then go forward from there. We have a few questions coming up, but we'll leave them till the Q&A session. What we might do now is start the case-based discussion with your complex case, Professor Atallah. I'll share the screen unless you prefer to, and then we can go through the case.
I have a problem. I cannot share the screen. I don't know what's happening.
Okay, so I'll share that screen. So this is your complex case of persistent HPV cervical infection. If you don't mind running us through the case, and then I can lead with the questions after, if that's okay.
Okay, perfect. Samir, you're invited, please, to start.
Hello, my name is Samer Tashishi. I'm a senior resident at Hotel Dieu de France under the patronage of Dr. Atallah. I will be presenting a case that we had in our institution. First of all, to present the patient, she is a 37-year-old female. She has had 2 normal vaginal deliveries with no problems at all. She has no real risk factors for an HPV or a persistent HPV infection, no tobacco use, not under any form of hormonal therapy, no corticotherapy, and no autoimmune disease. Also, our patient has no surgical history, no past medical history, and the patient, very sadly, did not receive any HPV vaccination. The problem started with our patient in 2021, where we had our initial diagnosis. On the co-testing done on January 2021, she started her year off with an LCIL on the pap smear and an HPV-16 infection that was positive. And so with the LCIL and HPV-16, we went to do a cervical biopsy, a colposcopy that was indicated. And on the colposcopy, we had a high-grade squamous intraepithelial lesion, CIN2. We also did an endocervical curettage, which was negative for dysplasia. So with CIN2 on the cervical biopsy and HPV-16 positive on the co-testing, we went to do her first conization. On the conization, we had a high-grade lesion. We had CIN2 with focally CIN3 that was detected. The margins were all free with more than 8 millimeter of lesion-free tissue. P16 was strongly positive, confirming the high-grade lesion for our patient. And so after her conization, echo testing was indicated after 6 months. The co-testing showed an ascus lesion, and the HPV-16 was always persistent. We had 2 co-testing done with an HPV-16 and an ascus lesion. And in June 2022, our patient had a planned hysteroscopy to remove an endometrial polyp that was benign. And also, we did a cervical biopsy. This time, the cervical biopsy showed a CIN1 lesion. On February 2023, we had a co-testing showing ascus with a persistent HPV-16 infection. And so we had 3 ASCUS and HPV-16 co-testings. And so for 2 years, she had her first co-testing with HPV infection in 2021. So here we had 2 years of persistent HPV infection on all the co-testing that were done. And so we were obliged to do a colposcopy that showed CIN2 and areas of chronic inflammation that were shown on her previous colposcopy also. The endocervical curtis showed no dysplasia, but chronic inflammation. In May 2023, due to her CIN2 on biopsy and HPV-16 positivity, we did the second conization for this patient. This time on the conization, we had a CIN2 and CIN1. The margins were always free, this time with more than 5 millimeters. We had a chronic inflammation, and the P16 was weakly expressed. For the post-conization surveillance, on November 2023, the pap smear showed LCIL, and the patient remained HPV-16 positive. On November 2023, following the LCIL and the HPV-16 that was always positive, we did a colposcopy. The colposcopy showed CIN1. We have to remember always that this patient had a CIN3 previously on the conization. The persistent HPV-16 on all the co-testing that was done. And so we did a leap this time for this patient that showed CIN1 and the margins were free. We also had chronic cervicitis with metaplastic transformation. On March 2024, 6 months after her leap, we also did echo testing as indicated. It was the first normal pap smear since diagnosis, but the HPV-16 was still positive. 6 months later, we did echo testing again, and the ASCUS, we had an ASCUS and the pap smear. The HPV was still persistent after 3 years of treatment. October 2024, the patient was very tired from a psychological point of view. This is a pathology where we have a really a big psychological burden for the patient, for the women. And so the patient has asked for hysterectomy. She was very tired of all her pathology. And the medical decision was made based on persistent HPV-16 infection despite multiple treatment, chronic inflammation and metaplasia, confounding cytological interpretation, and the patient has completed her parity and she has preferred an hysterectomy. On November 2024, a hysterectomy was done with the bilateral salpingectomy and the conservation of the ovaries. On the final histology, we had no residual cervical intraepithelial neoplasia. So for this patient, overall, on the span of almost 3 years, from 2021 till 2023, she did 9 co-testings. The HPV-16 was persistent on every single one of these co-testings. She had no clearance. 4 colposcopies all showed the cervical intraepithelial neoplasia, and 3 cervical excisions which showed the CIN1, CIN2, and CIN3 lesions. So this is the case. I can present some multiple answers questions if you would like.
Of course. So would you like me to read the questions, and or would you like to read them and then answer, and then we can also give Dr. Melhem if she has to add anything?
I can read them if you want. So for the first question, it is in the setting of persistent HPV-16 infection with repeated ASCUS or LCIL cytology and multiple prior conizations, what key factor justifies continued excision or ablative procedures rather than simple observation? Here we know that as our speakers already told us that HPV-16 is a very oncogenic virus, is a very oncogenic genotype. And the high oncogenic potential of this HPV-16 with an elevated risk of progression to cancer was a very an important risk factor for this patient. For the second question, according to international guidelines and expert opinion, which factor most strongly influences the decision to proceed with hysterectomy in a patient who has completed childbearing and has multiple excisional procedures for HPV-16 related dysplasia? Here, per the ASCCP guidelines, for a patient with more than 2 years of persistent HPV-16 infection, and showing on treatment cervical intraepithelial neoplasia, dysplasia, and this patient who has completed her parity and her preference was to do an hysterectomy, here an hysterectomy might be considered. And so for this patient, she insisted on an hysterectomy due to the high burden, psychological burden. So we did the hysterectomy, knowing that we should continue to monitor this patient for any lesions in the vaginal mucosa that persists. In cases of repeated negative margins on conization, but ongoing cytological abnormalities and HPV persistence, which of the following best explains why dysplasia can recur or appear to fluctuate CIN1 or 2 over time? Here, the viral latency, the patient had no clearance of the HPV-16 on the 9 co-testings that she has done. We had always a reactivation that was influenced by the host immune factors and chronic inflammation. We should also note that our patient had always a chronic inflammation on her biopsies. Before the last question, why is long-term follow-up, repeated co-testing at defined interval strongly recommended after each excisional procedure when HPV-16 remains positive, even if histology is only CIN1 or chronic cervicitis? Because HPV-16 persistence can eventually lead to higher grade lesions or carcinoma even after treatment, as we showed. Which preventive measure recommended by WHO and CDC might have significantly reduced the patient's risk of developing persistent HPV-16 infection and recurrent cervical dysplasia if administered appropriately? Here, if our patient has received any form of HPV vaccine at the adequate age, I don't think she would have had all this problem, and I don't think we would have known her in the hospital setting. And that's all that I have to present. Thank you.
I would like, thank you so much, Samer, for your intervention. I think there was some updates to the case study questions. So for the sake of time, I would like to invite Dr. Laurence if she has any input or like reflections that she would like to do on the case, all in all, before we move forward to the Q&A section.
Thank you. Just looking at that case, I mean, I do agree with the treatment because, I mean, she's been monitored very, very closely with the right surveillance. The way I look at it is after several treatments, and if she's finished her parity, some women don't clear the virus. At least 5 to 10% of women don't clear the virus. And so it becomes a question of, do we continue to have ongoing surveillance and treatment, or do we do a hysterectomy? But the important thing for people to understand is even if she has a hysterectomy, this does not prevent her from having ongoing surveillance with Volt smears, because the hysterectomy doesn't get rid of the HPV-16. It just eliminates the risk of cervical cancer. So she's still at risk of a Volt cancer or a VAIN tumor. So, you know, I do agree with this management that she was given the opportunity and her body just never cleared this virus. So I think the hysterectomy is definitely the way to go, given the medical impact it had on her mentally and psychologically as well.
Fantastic. Any comments, Professor Atallah?
I consider that, you know, we need to learn a little bit from Australia, and we need to take from their experience a little bit about how to implement the screening program and, most importantly, the vaccination program. And I don't know if you have any influence on, you have as an influence body at the Australian Lebanese Medical Association. I don't know if you have influence in the authorities in Australia, if they can help the Lebanese government by sending us a vaccine to vaccinate young girls, at least young girls, less than 14 years old, for one dose. You can do a lot for this country. Because, you know, do not look at the figure of 3.6 per 100,000, which is considered, you know, in Australia, less than 6 per 100,000 is considered as a rare disease. Less than 4 per 100,000, you don't need screening. Here, you cannot look at the 3.6 because it's artificial. It's not true. And those who are publishing these results are doing harm to the Lebanese population. Because here, we can no more have funds, no more can have help for implementing prevention or vaccination for our population. Because it's an artificially low figure.
Can I just ask, is the vaccination a routine thing in schools, or do people have to come and request it?
The people, it's out of the pocket, and each dose is around more or less than $200, and the people must come and request it. And moreover, the practitioners are implementing the 3-dose regimen for these young, which is unacceptable. It can vaccinate 3 persons, 3 doses effectively. At 10 years old, at 11 years old, let's say at 12, it can vaccinate 3 young girls for one regimen.
See, we're very fortunate in Australia. It's introduced in the school and it's all covered under a Medicare program. So when the children hit year 7 or their first year in high school, it's offered to everyone. And we strongly encourage it. The only people that don't take it are the people that their parents don't want them to. But we have a very high vaccination rate. And because it's introduced through the school program and it's all registered on registers, we're in a very, very fortunate position here in Australia. Very, very fortunate.
Sure. And we need you to help us in this implementing this policy. I don't know what's your leverage on the Australian government, or you can have some influence on the Ministry of Public Health in order to start doing something on that. I am in the 5 years cancer plan. I'm in the advisory board of the 5 years cancer plan in Lebanon. And I think that they are doing a lot of good things, and hopefully our new minister is an academic, is in the academic row, and I think he will continue. We had the previous academic also Minister of Public Health, and amazing, and now apparently is amazing, and so we are hopefully we are going to continue. We are lucky to have these ministers who are academician to continue the work that was done for the sake of our population.
Thank you. Professor Atalla, look, we've got a lot of projects that are running between Australia and Lebanon. They include cardiac, neonatology, and things like that. And I think we can certainly look into women's health and the HPV vaccination. It will be an ongoing project, nothing promised, obviously, for the next 12 months. But we will certainly, and I will personally push for it to add it to our agenda as one of our collaborations, especially that Australia is leading in that aspect. So thank you for bringing that up. Just based on the questions that have been popping up, and this question could be directed to both of you. There was a little bit of confusion regarding when to take the vaccines, when are they most effective. As you mentioned, Dr. Atalla, that one shot might be the most effective if you are taking it quite young, at that 12 to 14 Mark, is that accurate?
Yes, exactly. Exactly.
Yeah. And some people were asking, you know, from personal experience, for instance, when I moved to Australia, not having the vaccine, I did not receive the vaccine in Lebanon, but when I moved to Australia, I was actually offered the vaccine, and I was in my, you know, mid-20s. It was self-funded, so that was not covered by the government, and it is quite expensive. Like you were mentioning, you know, more than $200 for the 2 shots. I had to provide them myself. But some people were asking, are they still effective from, you know, your mid-20s onwards?
The data showed that the effectiveness starts after 4 years of vaccination. You know, after 4 years, statistically, you are protected after 4 years. To have an immediate effect, you have to do it before 17 years old. After 17 years old, those who were vaccinated before 16 or 17 never developed cancer in the follow-up. Those who were vaccinated, they had cancer somehow. That's why you need to screen these persons to continue screening. Still, if you screen twice a lifetime, those who were vaccinated early, you can practically annihilate the incidence, the presence of cervical cancer. So after 25, there is no efficacy. They can do it, but it's out of the pocket. Even the ASCCP, the American bodies recommend up to 26 years old. After 26, it has to be discussed with the patient. Now, there were studies. I saw a question here. There were studies about vaccinating after conization. These are studies, but there's a meta-analysis that's interesting from Jura. It's interesting. He found a sort of advantage of those who were vaccinated, but still, he discloses that there are uncertainties in this meta-analysis, and we need to have solid randomized trials in order to see if the vaccination, reminder, the vaccination only prevent, it doesn't cure, okay? So we need to have more solid randomized trial in order to make sure that this practice of vaccinating after conization is beneficial for these patients, if it's of benefit for these patients.
Okay. Dr. Melhem, would you like to add a comment about this?
No, I agree. Absolutely. Like in Australia, it is Medicare funded if they do it at the school child age. But as they get older, like you said, it is out of pocket and the effectiveness is significantly decreased. So, yeah, the benefit is definitely getting in early. And this is why we've tried to introduce it into our schools for young men and women to get the effect in as soon as possible. So, not much more to add other than what Professor has already mentioned.
Fantastic. One of the other questions was, is the Ministry of Public Health considering to add HPV to the national immunization scheme? And, you know, that would be, as we just discussed, ideal. And the vaccination that you would recommend would be, was that the quadrivalent one that you mentioned?
Nonavalent. The nonavalent, not the quadrivalent.
Not the quadrivalent.
Because the cross protection is larger. You have 9 subtypes of HPV, and the 66 that is the most frequent in Lebanon is partially protected by the nonavalent. And I looked at that. The 66 and the 35 are partially protected by the nanovalent, but it's a weak protection. Still, it's something if you want to address this virus that's most prevalent in Lebanon. It's better than the bivalent vaccine. Still, all these studies that I mentioned earlier about the efficacy of 1 dose or 2 dose at the beginning of these slides were about the quadrivalent or the bivalent vaccine.
One more question out of my interest. In Australia, for example, people who perform the screening, which was initially the pap smear and now it's the cervical screening, can range from ED physicians or, you know, ED trainees to nurses when you go to your family doctor, to family doctors, to obstetrics, gynecologists. So many people can perform that screening. Who does that in Lebanon? Who are the people screening?
Those who are screening are the doctors mainly here in Lebanon. Sometimes you have some midwives or some nurses that are in liberal practice, or they are working in a primary health care setting. They do the pap smear. And there are what we call the family practitioner. It's a sort of Canadian concept, you know. The family practitioners also perform pap smear
Perfect.
here in Lebanon.
Perfect.
Can I just ask, do they have self-collect in Lebanon?
Yeah, it's important what you're saying. The self-collection is very interesting and it has a future. But the problem here in Lebanon, how to send your collected sample. You don't have you don't have postal service. It's a very bad postal service in Lebanon. You don't have ways to if it's in a remote area, you need to implement a system of collection. So the government has to implement, if they want to implement the self-testing, still you must learn these in the remote areas to go and how to do the self-testing first. Second, you need to do a collection service. So it would be way more expensive than doing it in a primary health care that will be in the village, or doing it in their doctors or in the hospitals that are near, you know. But it's interesting, the self collection.
Thank you so much. This has been very insightful. Before we wrap things up, we have someone who has raised her hand. Her name is Amar. If you would like Christian to take her question live. So I just allowed you, Amar, to open your mic. So please feel free to ask your question. Amar, if you're still with us, you have access.
She has to unmute.
Yeah, I'll leave it up to her. She'd like to unmute, but either way, she'll come back to it. We still have like around 3 minutes, so if she would like, she can unmute at any time and ask her question. We have someone else. Her name is Samar. I will, or I believe not. So either way, if anyone would like to ask a question live, please raise your hand for us to allow you. Other than that, we still have 3 minutes up to go. We have already launched our second poll survey for you to fill it out. Yeah, I'll give it back to you, Christian, for you to share the final slides for our Q2 series. And yeah, thank you very much. We have someone, I believe, Salam. I will give you the ability to unmute if you'd like to. Yes, go ahead. Salam, if you're speaking, we cannot hear you, but you're unmuted.
Or, if any of these people would like to put their questions in the Q&A box, I'm happy to read them out. I think a lot of people were disheartened by the fact that you cannot, the effectiveness of the vaccine after 25 is quite minimal, because a lot of people have been advised to get the vaccine, even if they're above 25. And I think maybe the rationale is better than nothing. However, someone was asking also, if the vaccine doesn't work, then what should we do? And I believe the answer might be cervical screening would be the next step.
Exactly. And
Yeah.
those who do not have intercourse do not have to screen, no human contact, I mean by that.
Yeah, that's true. And that's the recommendation in Australia, is from the start of intercourse and 5 years from then, as long as you have a normal screen. Otherwise, closer if you have an abnormal screen.
It's not only heterosexual intercourse.
Yes.
It can be homosexual intercourse. That's important. No one is protected, huh?
But just to
Certainly.
add to, sorry, just to add to that, I mean, a vaccine is better than nothing. Like, I know the effectiveness is less, but in Australia, the teaching is that a vaccine is better than nothing. So even if you've been exposed, there is still a little bit of benefit. I mean, it's not the greatest, but something is better than nothing. So that's what Australia teaches.
Yeah. And in terms of Salam's question, there's a problem with the mic, but the question is already in the chat in the Q&A box. So the question was, as I understood, the young girl under 14 needs only one vaccine. If you can confirm on that.
Yes,
Yeah.
that's sure. Sure. Now, Australia and the UK are in the two vaccine regimen or single dose vaccine regimen. So single dose for less than 14, 2 doses after. So the single dose, and like Lawrence said, it doesn't make harm. Sure, in a country in Australia where everything is subsidized by the government, it's okay. But here in Lebanon, we need each dose, because if we do a dose that's not very useful after 25, we are losing this dose for a young girl that is less than 14 that can benefit 100%. So it's a waste, I think, for Lebanon, not for Australia. You are right, when you are able to vaccinate everyone, if she wants to pay for the vaccine, she can. But in Lebanon, you must think about effectiveness, the maximal effectiveness. Those who are after 25 must go and get screened with primary HPV typing virus. That's important. Before they need to go and do what we call the HPV vaccination. One dose before 14. We must push towards that. And really, we are trying to spread our voice and try to say that to all the bodies in Lebanon and the government in order to help us in implementing this logic way. It's not a rich country, Lebanon. It's no more the Lebanon.
And the data is not that accurate with the diluted denominator. So it's not presenting as a high incidence, high risk cancer to you.
Exactly.
Definitely. And Christian, I don't know if you can see the Q&A box. If you want, before we wrap up the last two questions, if you'd like me to read them or you'd like to take the lead and go ahead with wrapping up.
I thought I went
would
through
you like me
most
to
of
read them?
them.
So I will be
Sure, maybe I've
Yeah,
missed them, because
so
most of them were about ages, and I think we did cover them. But yes, please go ahead.
yeah, so I will just read the other question of Salam, because I believe it was administered or submitted after they were trying to speak. So when the tests show positive HPV, how can we know from when the virus has been taking? And this is the last question that we'll be tackling before wrapping up.
Would any of you like to answer? So I think the question is mainly, how do we know when did the virus start? Yeah, I don't know. I don't know if we'll be able to.
Yeah, I don't think you can really tell when. I think they say from your first sexual contact, there should be screening. And in Australia, we start that screening at age 25. But once you've picked up on the HPV, I don't think you can track back to when it sort of first became active. But we basically start our screening from first sexual contact and moving forward. I think that's the only way you could answer that question.
And it's important to notice, because we are encountering problems with couples coming from with a new HPV finding that is telling me that I was always negative. What happened is my husband cheating. Nobody can tell she is cheating, her husband is cheating, or maybe she caught the virus 20 years ago. And that's a true problem. They must know that the virus can be dormant, the virus can reactivate you know. And the problem of HPV virus, when it invades the epithelium, it doesn't create any immunity reaction. Instead, the virus is able to shut down the interleukin, and you can maybe have a silent infection that's not like any other viral infection. You have flu, you know that you have flu. You are contaminating with HPV. It's very silent. It invades, it's very silent. It doesn't create any reaction. It doesn't create any even immunity. You don't have immunity against the virus once you have caught it. So that's important to note that. And the virus can stay there for years and for lives. If sometimes it's screened when you do the pap smear, sometimes it's not. That's why you need to search for the virus if it's there or not.
And that's why it's important to do the screening regularly, not once in your lifetime.
And in Lebanon, in our series, we have the largest series in the country of more than 5,000 patients that were screened with primary HPV testing. We had persons that had negative HPV with high-grade dysplasia. And we found by tracking these patients, we found that, you know, when you are doing a test, there is a threshold for the test to detect it. We have the OnClarity test, which is a highly effective test. You have a threshold. If the virus load is below the threshold, you do not detect the virus. So that's why we need to continue in a closer manner the follow-up of these patients. Instead of doing it every 5 years, we are doing it every 3 years. As I've said, we have a lot of patients that are HPV negative, but they have dysplasia. That's why the vaccination is important at 14 years old, at 13 years old.
Yes, gold standard. And hopefully you will be able to implement it one day in the national vaccination scheme. That will be the future. I really want to thank you both, Professor Atallah and Dr. Melhem, for your time. You know, either spending this time late in Lebanon or waking up that early in Australia, sharing your expertise, your time is very invaluable for our diaspora. And this has been very enlightening. And thank you very much to everyone who's participated and who's attended. And definitely, Ma'ali al-Wazir is not with us anymore, but I extend big thanks to him for attending and giving his time to this cause. And hopefully his team will brief him that this is a very important public health issue.
Thank you.
As for what's coming soon, please stay tuned. We've got a Lebanese social media channel, apparently, and there will be a webinar series in the second half of the year. So please stay tuned to that. I'm sure Maurice will inform you all. And if no one has anything to add, I will wish everyone a good night or a good day to us in Australia.
Thank you. Thank you for the opportunity. Thank you.
Thank you for the opportunity. Thank you.
Bye.